Welcome back. Dr. Leah Floyd is a social behavioral scientist with over 20 years of experience in substance abuse prevention research. She received her Ph.D. in psychology from Howard University and completed a 3-year postdoctoral fellowship in drug dependence epidemiology and prevention at the Johns Hopkins Bloomberg School of Public Health. Currently, Dr. Floyd is an associate professor in the Department of Psychology at Norfolk State University. Her research program centers on preventing substance use disorders in African American emerging adults. In addition, a major focus on her work is elucidating and explaining racial disparities in poor outcomes associated with marijuana use by considering the extent to which contextual factors interact with marijuana use behaviors to produce different outcomes across different groups. Dr. Floyd's research has been funded by the National Institute on Drug Abuse, and her work has been published in scientific journals like Addictive Behaviors. Additionally, Dr. Floyd holds memberships in numerous professional organizations, including the American Psychological Association and the Society for Prevention Research. Thank you, Dr. Floyd.
So good morning. Is it still morning? Yes. Can everyone hear me okay? Okay, great. So let me begin to share my screen with you guys. Okay, how is that? Can everyone see that? Okay, so the title of my talk today is Toxic Neighborhoods and Marijuana Use Behaviors and Outcomes in Emerging Adult African American Females. So in my bio, you were provided with information about my professional background and my research interests. But I would also like to share with you just a bit of my lived experiences, which have influenced my work in substance use among young persons, and specifically African American young persons. So briefly, I grew up in a small town in North Carolina, which happens to be the same town that attorney Ben Crump grew up in. And ironically, we grew up in the same community. And for all intents and purposes, this community was considered a poor community. And although we were considered to be a poor community, we didn't think of ourselves as living in poverty. And more importantly, we were a very close-knit community. But then in the late 80s, early 90s, like most urban areas in the United States, my small town struggled with the drug epidemic, the crack epidemic. And so as the crack epidemic evolved in my small town, many of my friends became engaged in either drug dealing or drug using. But some of us made it out, like Ben Crump, like me, we made it out. And so for me, the question became, why? Why was it that some of us made it out and were successful while others fell victim to the crack epidemic? So I fast forward, went to Howard, ended up at Hopkins, and became a scientist studying this question, trying to find answers to this question. So my work is greatly influenced by my lived experiences, as well as the current public health crisis evolving around marijuana use and other drug use among young persons. So let's jump into this. Current trends in substance use. Specifically marijuana. We are seeing more and more states legalizing marijuana for medical and or recreational use. And the legalization of marijuana is essentially sending the message that marijuana is a safe drug. And we are seeing greater acceptance of marijuana use in our society. Well, I would like to say that I don't think there's any such thing as a safe drug, first of all, or a harmless drug. And so for me, it's important that people, young people, old people, that we understand what is known about both the adverse effects of marijuana as well as the potential therapeutic benefits linked to marijuana. So if I were to ask you guys, if I were to poll you guys and ask, how many of you smoked marijuana at some point in your life, as a teenager, as a college student? And I'm willing to bet that most of us would say that, yes, I experimented with marijuana at some point. Some would even say that they became recreational users of marijuana. With that being said, what I would like to point out is that the marijuana that you smoke is probably not the same marijuana that is available currently in the United States. So this slide is basically giving us a snapshot of how levels of THC has increased over the past 2 decades. So over the past 2 decades, the marijuana that is currently available and being used, the level of THC is significantly higher than that of the marijuana used 20 years ago, 30 years ago by our parents, by many of us. And the fact that the marijuana that is currently being consumed has higher levels of THC than that we use, this means that for many individuals currently using this marijuana, they are being exposed to high levels of THC with a greater chance of experiencing an adverse outcome or a harmful reaction. So I always tell my students who say marijuana is harmless, I say marijuana may be less harmful than cocaine or heroin, but it is not a harmless drug, especially given the high concentration of THC in the marijuana that is currently on the market. Current trends in using marijuana, there are a number of different strains of marijuana. The marijuana industry is a very complex industry. And when I conduct research, I always ask my participants about the type of marijuana that they typically use. And so marijuana is basically broken into what they refer to as Reggie, which is regular marijuana, the marijuana with the lower levels of THC that we probably consumed 20 years ago. And then there is the category of exotic marijuana. And this is the marijuana that has high levels of THC. It is more expensive, and it seems to be the marijuana that is preferred by many of our young people. So current methods of consuming marijuana have also changed. 20, 30 years ago, joints were probably very common, or the most common method for consuming marijuana. Now we use blunts, and blunts are simply cigars that they remove the tobacco from the cigars and fill it with marijuana and smoke it. So you have a large amount of marijuana being consumed in a short period of time. And again, this marijuana is typically the marijuana with high levels of THC. And then we have edibles, which often comes in the form of candy. So while this may look like our harmless sweet tarts, these are actually sweet tart ropes that are infused with THC. And then vaping is also a common form. And the pen at the bottom is typically what is used to vape marijuana, to vape THC. So when they are vaping, they are actually using or consuming pure THC. So this produces a very intense high, which, needless to say, is probably related to more increased risk of addiction or cannabis use disorders. So currently in the United States, emerging adults, that is individuals between 18 and 26 years of age, have the highest rates of marijuana use. It is during emerging adulthood that marijuana use peaks, while secular trends indicate that marijuana use is common and has increased across racial and ethnic groups as well as gender. What is apparent is that there are racial disparities in marijuana use. So for example, monthly marijuana use, 66% of whites compared to 80% of Blacks report monthly marijuana use. Weekly marijuana use is reported by 48% of whites compared to 61% of African Americans. And I am having some technical difficulties. Can you guys see that okay again? In addition, when we look at gender, we know that there have been significant increases in marijuana use among females. In a study by Zhu and Wu, published in 2017, they found that between 2007 and 2011, hospitalization for cannabis use disorders increased by 39% for females. Racial disparities among females were also apparent. Non-Hispanic Black females have the highest rate of cannabis use disorders. Their rate is 138 per 100,000 persons, compared to 53 per 100,000 persons for white females and 69 per 100,000 persons for Hispanic females. So again, my question is why do some groups, some individuals engage in chronic marijuana use more than others and have higher rates of cannabis use disorders and experience poor outcomes at greater rates than other groups. So ecological models suggest that African Americans' increased risk for cannabis use disorders and associated adverse outcomes result in part from chronic exposure to contextual disadvantages, such as living in economically deprived and socially disorganized neighborhoods. In the United States, African Americans are disproportionately affected by poverty. They disproportionately represent those living in poverty. For example, 27% of African Americans compared to 11% of whites in urban areas live in poverty. Black families, which are primarily headed by females, are significantly more likely to live in areas of concentrated poverty. These are neighborhoods or communities in which 20% or more of the residents are poor. So for example, this is a map of Baltimore, of the Baltimore City area in Maryland. As you may know, Baltimore is one of the poorest urban areas in the United States. But like many other urban areas, Baltimore's neighborhoods are very much segregated. So in this particular map, the dark blue areas represent communities in which 75% or more of the residents are African American. Okay, so the dark blue areas. The dark blue areas that are outlined in red, the red line represents or indicates that the level of poverty, the poverty rate is above 20%. So clearly there is an overlap between African American neighborhoods and areas of concentrated poverty. So what does this mean? Relative to whites, Blacks are more likely to be poor and to live in communities characterized by concentrated disadvantages. They live in communities that are crowded and are detrimental to both physical as well as mental health. Racial differences in poverty and associated community conditions often result in racial ethnic differences in exposure as well as vulnerability to risk for substance use and its consequences. So one would say that if you talk to public health researchers, many would argue that the way we ended these disparities or prevent these disparities is through creating equitable neighborhoods. Creating equitable neighborhoods. But for many of us who are attending this symposium, we are not government officials. We are not politicians. Our focus is typically on the individual. So until our politicians and the powers that be are able to establish, create equitable neighborhoods, we therapists, psychologists, social workers who are on the front lines, we, along with researchers, must create, develop interventions, and implement practices to reduce the risk for substance use, marijuana use disorders, and adverse outcomes associated with marijuana use among those who are most vulnerable, who tend to be African Americans in disadvantaged neighborhoods. So at the individual level, I argue that we must identify factors that place these people or individuals residing in disadvantaged neighborhoods at increased risk, because it's highly unlikely that they can move from their neighborhood, right? So let's identify risk and protective factors that we can target for change. So in the literature on neighborhood effects and on marijuana use, what we find is that most studies focus on the relationship between neighborhood economic and structural factors and how they influence marijuana use behaviors and outcomes. So neighborhood disadvantage refers to areas with few economic resources. Neighborhood disorder is a variable or factor that we can possibly address. Perceived neighborhood disorder is essentially an individual's perception of signs of breakdown in social disorder and control in their neighborhood. Neighborhood disorder is characterized not only by levels of poverty, but criminal activity, drug dealing, low social cohesion. How do you interact with your neighbors? Do you trust your neighbors? As well as physical decay. So our goal is to design place-based interventions that are specific to neighborhoods that are deprived in terms of economics. And within these neighborhoods, we want to target those individuals who are at greatest risk for engaging in excessive marijuana use and cannabis use disorders. So an individual level factor that may signal risk is perceived neighborhood disorders. How do you perceive your neighborhood? If you perceive your neighborhood as disordered or as stressful or threatening, this may place you at increased risk for excessive marijuana use and cannabis use disorders. The theory of social disorganization suggests that neighborhood disorder is a chronic stressor. And we know that exposure to chronic stress is positively associated with increased substance use. There is an extensive literature focused on explaining the relationship between chronic stress and substance use. So I argue that the degree to which an individual perceives his or her neighborhood as threatening may be related to marijuana use behaviors and outcomes. And this is an individual level factor that we, therapists, researchers, psychologists, social workers, can use to identify and even change in order to help individuals. So in my first analysis, I was interested in determining the extent to which perceived neighborhood disorder influences marijuana use frequency in a sample of emerging adult African-American female residents of low socioeconomic status communities in Baltimore. So I recruited 120 Black females between the ages of 18 and 30 who resided in economically disadvantaged neighborhoods to participate in the study. So after we received informed consent from each participant, they were administered a semi-structured HIV risk-taking interview. The interview was conducted by trained research assistants. And within this interview, we asked detailed questions about substance use, marijuana use, cocaine use, heroin use, as well as risk-taking behaviors. We also asked them to complete the neighborhood environment scale, which measured their perception of neighborhood disorder. We asked them to provide us with a urine sample, which was tested for the presence of psychoactive drugs, including marijuana, cocaine, heroin. In addition, we asked detailed questions, we asked them to self-report monthly marijuana use in addition to weekly marijuana use. Finally, they were administered a neuropsychological and neurocognitive assessment to measure things such as executive functioning, behavioral disinhibition, and other neurocognitive characteristics. So our sample included, again, 120 African-American females. The mean age was 24. 30% of the females did not complete high school. The majority were unemployed. The majority received welfare benefits. 68% reported that they did not have enough money to meet their needs. 27% indicated that they used marijuana 15 or more days in the past 30 days. So that is essentially 3 or more times a week. Our measurement of neighborhood disorder, as we would expect, the majority of our participants reported perceiving their neighborhood as being disordered, disorganized. Because so many of our participants reported disorganization, we decided to compare those in the highest quartile to those in the 3 lower quartiles in our data analysis. So we have 2 groups, those with the highest scores on neighborhood disorder, and then those who were in the 3 lower quartiles. We also created 3 marijuana use groups. The first group was those who reported no marijuana use in the past 30 days. The second group included those who reported between 1 and 14 days of marijuana use in the past month. And then we created a group of individuals who reported 15 or more days of use. So these are the people that we refer to as frequent or heavy users of marijuana. We use logistic regression to determine whether level of perceived neighborhood disorder predicted membership in the monthly marijuana use groups. And indeed it did. Level of perceived neighborhood disorder influenced whether or not you were a frequent marijuana user or a no, or an abstainer. So if we look at this bottom row, what we see is that those in the highest quartile of neighborhood disorder were more likely to be heavy users or frequent users of marijuana. They were 3.3 times more likely. Persons who reported high levels of neighborhood disorder were 3.3 times more likely to be heavy marijuana users. So going back to this idea that that neighborhood disorder is a chronic stressor, we suggest that these individuals may use marijuana in excess as a means to cope with their threatening neighborhood environment. So for those of us who are treating these individuals, for those of us who are designing interventions, we should focus on improving strategies, improving coping strategies that will help to mitigate the ill effects of living in these toxic neighborhoods, these disordered, stressful neighborhoods. So my second research question is really trying to understand how marijuana may create or influence or produce negative effects on executive functionings, including impulse control. So I asked the question, to what extent does neighborhood disorder amplify the effects of marijuana on disinhibition, which is also referred to as impulsivity, in this sample of Black females? So what research tells us that poverty not only affects substance use behaviors, but poverty also has an impact or can negatively affect one's ability to control impulses. Now, there are a number of proposed pathways through which poverty may influence neurocognitive functions, such as impulse control. One pathway is through exposure to environmental pollutants and neurotoxins. What we know is that from environmental justice research is that poor neighborhoods are oftentimes located in areas in which there are a lot of environmental pollutants. These environmental pollutants have a negative impact on health as well as neurocognitive functions. In addition, poor neighborhoods oftentimes are made up of houses that are poorly constructed, houses that are old, houses that when they were built likely used materials that are known to be neurotoxins, such as lead-based paint. And exposure to lead-based paint and other materials can have a negative impact or effect on neurocognitive functions, such as being able to control your impulses. The second pathway is through exposure to chronic stress, neighborhood disorder. Again, neighborhood disorder is considered to be a chronic stressor. Long-term exposure to this chronic stress produced by concentrated poverty also can have a negative impact on impulse control or your ability to control your impulses. Reidner and colleagues in 2013 conducted a study in which they attempted to determine where youth with behavioral disinhibition, high scores on behavioral disinhibition, where did these kids actually live? And they found that youth with high scores on disinhibition tended to cluster in disadvantaged neighborhoods. So supporting this idea that poverty impacts one's ability to control impulses. More recently, Tomlinson and colleagues found that greater neighborhood poverty predicted poorer performance on a disinhibition task. So again, there is growing evidence that poverty adversely affects your ability to control your impulses. Ongoing neurodevelopment in emerging adults makes them especially vulnerable to the negative effects of long-term exposure to poor living conditions on the prefrontal regions of the brain responsible for impulse control. So again, poverty can negatively impact your ability to control impulses. Now, in a second and separate line of research, there is growing evidence that regular marijuana use, especially during adolescence and emerging adulthood, disrupts the development of the prefrontal regions of the brain that control inhibition. It is suspected that this is because there are higher concentrations of cannabinoid receptors in the neural fiber tracts of the nervous system during adolescence and emerging adulthood. And this contributes to their increased vulnerability to the effects of marijuana on prefrontal regions of the brain that control inhibition. So why is it important to understand inhibition and impulsivity? We are particularly concerned with impulsivity because we know that impulsivity or disinhibition is associated with a number of adverse outcomes, including poor educational outcomes, including HIV risk-taking behaviors, including delinquency, as well as addiction. So again, my research question is, to what extent does neighborhood disorder amplify the negative effects of marijuana on disinhibition? I argue that the effects of marijuana may be more detrimental for young persons residing in disadvantaged, disorganized neighborhoods as a result of exposure to chronic stress and neurotoxins that affect brain development and maturation. So using the same sample of 120 African-American females, we explored this relationship. In this analysis, we used the results from the urine samples. And the results from the urine samples indicated that 45% of the females had used marijuana recently. within the last 30 days. So we created 2 marijuana use groups based on the results of the urinalysis. The groups we created were those who abstained from marijuana use, they did not test positive for THC, and those who tested positive for THC. We used logistic regression to determine whether perceived neighborhood disorder actually amplified the effect of marijuana on disinhibition in the sample. So our preliminary analysis indicated that users of marijuana, those who tested positive, scored higher on behavioral disinhibition compared to non-users. For non-users, the mean score was about 25. For users of marijuana, the mean score on behavioral disinhibition was about 32. So clearly, users have a deficit or are experiencing deficits in impulse control compared to non-users. So these are the results from the logistic regression analysis. The orange dotted line represents females who reported the greatest levels of perceived neighborhood disorder. The blue line represents females who reported lower levels of neighborhood disorder. What we see is that females who reported high levels of neighborhood disorder and who used marijuana performed worse on the behavioral disinhibition test than females who used marijuana but did not report high levels of neighborhood disorder. So this suggests that the effects of marijuana on behavioral disinhibition are more pronounced in African American females who report higher levels of disorder. Disorder, again, is a chronic stressor. So, in summation, the findings from these two analyses suggest that females experiencing high levels of neighborhood stress may be at heightened risk for developing a cannabis use disorder. The findings also suggest that perceived neighborhood disorder may amplify the effects of marijuana on disinhibition. Ultimately, these findings highlight the importance of considering the context in which marijuana use occurs, because the context in which marijuana use occurs likely impacts outcomes associated with marijuana use. So the take-home message is chronic marijuana use among African American females, specifically those from low socioeconomic status backgrounds, is a major concern. Among these females, neighborhood disorder may be responsible for producing differences in marijuana use behaviors. Neighborhood disorder may also amplify or produce more pronounced negative effects of marijuana on impulse control. I argue that marijuana use can place these females at a cognitive disadvantage and on a long-term trajectory of disadvantage, which will lead to lower quality of life. So what can we do as therapists, as social workers, as psychologists, as mental health professionals who are treating these individuals, who come across these individuals on a daily basis? Multimodal interventions such as cognitive behavioral stress management, implementing these type of practices, teaching individuals to cope with or manage the stress of living in disadvantaged neighborhoods may offer some protection against the adverse effects of neighborhood disorder, as well as strengthens one's ability to control impulses. We can engage our clients in cognitive exercises that may produce better outcomes with regards to controlling impulses, improve their ability to make decisions. At the community level, coalitions charged with improving the social conditions of communities through strengthening social cohesion and fostering pro-social networks are necessary. So for those of us who are involved in community-based organizations, one of our aims should be strengthening social cohesion and fostering pro-social networks to help reduce the threat of living in these neighborhoods, or the perceived threat. At the level that is probably above each of us, the macro level, we need to encourage our policymakers, our politicians, to enact policies directed at improving these neighborhoods, improving physical features, such as providing safe, affordable housing, creating neighborhoods with green space, in an effort to reduce crime, in an effort to reduce perceived neighborhood disorder. This is critical for improving the mental health of these residents and potentially reducing marijuana and other substance use among the residents. So, in conclusion, I would like to acknowledge the National Institute on Drug Abuse for providing funding for the study, the research participants in Baltimore City, as well as my study staff and my colleague, Dr. William Latimer. At this time, I will open the floor up for any questions or comments.
Yes, Dr. Floyd, you have several questions that have come through the Q&A. So if you'd like, I can just kind of roll through those.
Absolutely.
Okay. The first one is, wouldn't integration help lessen the gap and afford more opportunities for success?
Could you repeat that?
Sure. And this question came in a while ago, so that might be hard to think back to what you're talking about. Wouldn't integration help lessen the gap and afford more opportunities for success?
Absolutely. Integration, as well as creating, I touched on that when I suggested creating equitable neighborhoods. We know that there's a lot of gentrification also taking place in many urban areas, such as Washington, D.C. I think that is a perfect example. So by integrating these neighborhoods, this would absolutely help to address this concentrated poverty and reduce segregated neighborhoods that experience high levels of poverty. So to the extent that we can integrate neighborhoods, to the extent that gentrification actually creates integrated neighborhoods, this would definitely address some of these problems. But unfortunately, what we see in integrated, when we are attempting to gentrify these neighborhoods, urban neighborhoods, oftentimes what we have seen is that the housing prices become so expensive that the residents who originally inhabited these communities are forced out. So they are forced out and forced back into segregated, disadvantaged neighborhoods. So the issue is very complex when we talk about integration and gentrification of neighborhoods.
Okay, thank you. The next question is about, I think, your survey participants and how were the females recruited to be a part of your study?
Okay, so the way we recruited our females is that we identified neighborhoods in Baltimore that were segregated neighborhoods where concentrated poverty was prevalent, where there was concentrated poverty, and the majority of the residents were African Americans. We used recruiters to go into these neighborhoods to recruit participants. We also partnered with community-based organizations to help recruit participants. In addition, we advertised on social media sites and in newspapers as a means for recruiting participants to be in the study. We actually only included females who reported, who did not report the use of cocaine, heroin, and other hard drugs. So we wanted to specifically focus on females who had not progressed to the more intense illicit drugs. So this sample included non-users of marijuana, marijuana users, and those who used alcohol.
Okay, thank you. A few more questions to get through here. Next one is there a correlation to crime as well and trauma or stress?
Is there a correlation between trauma and stress?
And crime, I think, to the outcomes of the study.
Well, I did not look at crime as it relates to marijuana use frequency or neurocognitive functioning. As well as with regards to trauma, we do have measures of trauma, but we have not looked at the associations.
Okay. Next question for you is, Dr. Floyd, what have you seen in terms of prevention programs that have been effective in reducing the number of users or decreased cannabis use disorder?
With regards to intervention, again, my research team, we are also in the process of testing and developing an intervention which is referred to developed by Dr. William Latimer, and it essentially is called the Integrated Family Cognitive Behavioral Therapy. And so again, one idea is to introduce techniques to teach participants how to better cope with living in these stressful communities. Because if they are able to better cope, the idea is that they will be less likely to progress to heavy marijuana use, which oftentimes results in cannabis use disorders. In addition, we're implementing exercises, cognitive exercises that again are designed to boost individuals' abilities to make decisions and to improve their ability to control impulsive behaviors.
Okay, next question. You present excellent details that connect the context of the individual's experience and their susceptibility to substance use as a coping mechanism. Does your research indicate any differentiation between neighborhood disorder versus other contextual factors?
Versus other contextual factors?
I think asking what beyond, was anything looked at beyond neighborhood disorder with this study?
With regards to neighborhood. So with regards to neighborhood, perceived neighborhood disorder was the self-report measure that we used. We were also able to collect the addresses of our participants and geocode and map them to look at how marijuana use behaviors overlapped with things such as areas with high crime. But again, our sample was recruited from neighborhoods with high that had high crime and high levels of poverty. So although we were able to, although we have these objective measures, they overlap with social disorganization, if that makes any sense.
Mhm.
So we have objective measures of neighborhood economics in addition to the self-report measure of perceived neighborhood disorder. But because we were looking at a specific population, there's not a lot of variance, as you would imagine, with regards to neighborhood characteristics. So the variance that we were concerned with was essentially variation in how you perceive your neighborhood.
Okay, and I'm going to combine two questions here in the interest of time. Someone asked what area was the study conducted, and then there's another question about compensation for individuals in the study.
Okay, the area again was, we recruited participants from Baltimore City neighborhoods, the inner city of Baltimore, which included West Baltimore and East Baltimore, as well as some neighborhoods in Southwest Baltimore. Our participants were compensated. They did receive $35 for their participation in the study.
Okay. And hopefully we can get through all of these in the next 3 minutes, but if not, perhaps you can individually answer these directly. I know folks are going to want to get to their lunch soon, but would it be safe to say marijuana keeps you from being motivated and leaves you satisfied with the bad situation and not having motivation to change your life?
Interesting question. And it's actually a question that I am interested in researching more. And I actually have a measure of apathy. So my next analysis will include this measure of apathy and how it relates to various outcomes, various behaviors within this population, because motivation is a major core component in changing behavior. And anecdotal data suggests that a lot of my participants lack the motivation to change. And marijuana use may increase this lack of motivation. So motivation is one of the variables that I'm definitely interested in exploring more as it relates to changing behaviors as well as marijuana use outcomes.
Okay, given your research about this risk factor, what protective factors can enable these young women to overcome their challenges?
In terms of protective factors, again, I think that improving coping strategies, providing them with adaptive coping strategies would be a protective factor. Some research suggests that spirituality is a protective factor against the adverse effects of living in these disorganized neighborhoods. In addition, a protective factor for some populations is education. In my sample, you saw that I think 38% did not complete high school. And in my first analysis, your level of education, whether or not you completed high school, was related to frequency of marijuana use. So education seems to be a protective factor. So to the extent that we can help these young people continue their education may also help to protect them against these adverse effects of living in these communities.
Okay. Okay, this is a long one, and then there's a quick short one. So the longer one, what do you say to individuals that are adamant about continuing to use marijuana as a coping skill? I've often heard from clients that therapeutic coping skills can take too long to be effective and marijuana is quicker. They've also shared that they're not concerned about the health and psychological consequences of using marijuana because they do not care what happens to them. And then the last question just is another study question where the individual wants to know if you looked at how they were using marijuana, like smoking, vaping, edibles, Delta 8, like did you look at that in the study?
So yes, I did look at how they were using marijuana, and the majority of the participants in the study consume marijuana through the use of blunts. I'm currently conducting this study again in Norfolk, and I'm asking the same questions related to edibles, vaping, and just using smoking marijuana. And again, among African Americans, the preferred method seems to be using blunts to consume marijuana. And then the first question, if I can remember it.
Oh, it's about what would you say to individuals that are adamant about continuing to use marijuana as a coping skill? So how would you work with their ambivalence?
So individuals, and I come across this a lot, they are adamant that marijuana use helps them. They will continue to use. They don't want to, African Americans tend not to utilize mental health services as much, and marijuana may be a form of self-medicating and reducing depression and anxiety and all of those things. So a lot of my participants, I do suggest that they will not stop using marijuana. And so one of my goals is to, one, first educate them about the harms of marijuana. Two is to provide them evidence of the effectiveness of prescription drugs, and to attempt to reduce the stigma associated with prescription drug use to deal with the anxiety or the post-traumatic stress disorders that are becoming more and more common in this particular population. So I think that, it's important not only to educate them, to provide them with alternatives to marijuana use, and again, to really make sure that they understand how marijuana is impacting them. And I also like to talk to them about how the level of THC has increased over time and what the implications of this could be for their well-being. But again, I think it goes back to one of the previous questions about motivation and seeing this lack of motivation to change, or to even, engage in activities that will lead to a better life. So we also have to kind of deal with apathy and this lack of motivation. So it's very complex. There's no one answer.
All right, well, that concludes our Q&A. So thank you so much, Dr. Floyd. Your presentation generated a lot of questions. A lot of people were very interested in your research and had some good follow-up there. So I'm going to turn it back over to Mia.
Okay, and so again, my email information is provided, so feel free to reach out to me. I would love to discuss my research and hear your ideas about possible solutions and directions. Thank you.
Mia, you're
Mia,
muted.
you're on mute.
Yeah, it's because I'm so excited. Thank you so much, Dr. Floyd, for your presentation, and to all of our presenters. This is only day one. So thank you for joining us today, and please remember to complete the brief evaluation if you are requesting CEUs, and see you tomorrow at 9. Thanks again.
Thank you.